Hello, everyone, and welcome to 2020 National Midwifery Week. My name is Dr. Cassie Belzer, and today we are going to be presenting on the midwifery pearls of telehealth. Joining me are my colleagues from Frontier Nursing University, Dr. Audrey Perry, Heidi Loomis, nurse practitioner and nurse midwife, Dr. Judith Butler, Martha Harvey, certified midwife, and Dr. Tanya Belcheff. This presentation is going to provide you with an overview of telemedicine from a midwifery perspective with social emphasis on the areas of patient engagement, group provider care, provider satisfaction, and best practices for meeting compliance requirements. At the end of the presentation, we want you to be able to state 3 strategies to improve participant engagement in telehealth visits, 3 strategies to facilitate group prenatal care telehealth practices, identify the most common errors made that lead to dissatisfaction or loss of revenue, and state 3 best practices for protecting privacy and confidentiality. Also, 3 common rules and regulations that vary by state that may impact your practice. Next slide. Telehealth is a collection of means or methods that enhance healthcare, public health and health education delivery, and support by using telecommunications. It encompasses a variety of technologies to delivery of virtual medical health and education services. There's not one specific service, and some of these are patient portal use, video calls, audio calls, interactive patient care, remote patient monitoring, store and forward, and media streaming. Next slide, please. There's an urgency for midwives to take on telehealth. Especially during COVID, we've noticed that there is a disparity in the opportunity for people to get good care. The US has 3.8 million births per year. 1 out of every 16 births, or 6.2%, have no or late prenatal care, and 1 out of 7 have inadequate prenatal care. This equals a lost opportunity for us to stop having bad outcomes. We could, if we had telehealth, prevent or early diagnose diabetes, hypertension, obesity, preterm birth. In 2020, ACOG noticed a shortage of up to 8,800 OBGYNs. In 2050, there will be a shortage of 22,000 OBGYNs. In 2017, ACANM noted 40% of US counties lacked providers for prenatal and antenatal care. Next slide. These next 2 maps are going to demonstrate what we call maternity care deserts. If you notice Alaska in the middle of America, those are the most dense and where we are lacking access to care. If you think about Alaska, a lot of these individuals have to deal with environmental factors. Even in Montana, people in the wintertime have to get on sleds or airplanes or helicopters to reach care in order to get through the snow. Next slide, please. This is a March of Dimes slide saying that there's no OB providers in the very dark green. Again, look at Alaska in the middle of America. Next slide. So we're looking at the lost opportunities of preventing bad outcomes. In the US alone, 10% of all babies are born to preterm birth. That's $26.2 billion a year in medical and social expenses. Low birth weight, 8.3% of all babies are born in low birth weight. Hypertension costs the United States $2.818 billion per year. Diabetes, in the US, 1 to 2% of pregnant women start with diabetes, and 6 to 9% develop diabetes. This costs the US $1.6 billion for diabetes alone in pregnancy. In the US, 55% of Americans are greater than what normal weight should be. And that costs $3.5 million that affects 3.5 million births per year. 32% of the US pregnancies end in C-section, which is about 32K versus 51K, 32,000 births per birth per year. Sorry. Cost of excess would be 2.32 billion globally. Next slide. These next few slides, I'm going to go over some important points that if you're going to adopt telehealth, you need to know some of these laws. A good place for you to find these laws would be in the Center for Connected Health. For example, in Montana Medicaid does not reimburse for store and forward or remote patient monitoring, but it does pay for live video care in some circumstances. Versus in Colorado, it does reimburse for some remote monitoring for certain chronic health conditions. But the most important factor is that you need to know where your patient is. If your patient is in Colorado, but you're practicing out of Montana, you're going to follow a Colorado law. Be aware of the Stark and antitrust laws. No provider can refer patients to entities that they or immediate family members have a financial relationship with. The anti-kickback statute makes it illegal for providers to knowingly and willfully accept bribes or other forms of remuneration in return for generating federal health care program business. Next slide. During COVID, the Health and Human Services Office stepped up to the plate and waived lots of HIPAA enforcement. That way more people could get access to care in a safe manner. They allowed for Facebook Messenger, FaceTime, and Skype to be able to be used as a platform to provide telehealth. However, it is ideal that you use a specific telehealth platform if you're going to continue, because these laws will not necessarily continue throughout. They allowed more practitioners to get reimbursed, including physician's assistants, nurse practitioners, midwives, social workers, and nutritionists. And remember, again, you must be licensed in your patient's state. Some important terms that you need to know: parity. Parity means that the state you're practicing in has a law that private payers have to reimburse for telemed care in the same way they would for in-person care. Originating means the patient location, and distant means the provider location. So can you collect an origination fee? If you are collecting a fee, the originating and distant cannot be in the same facility. The originating must bill a specific code to charge this fee, and it must ask for it from the distant prior to the appointment, or you will not be able to collect that fee. Originating cannot bill for assisting the distant with an exam or anything that would have happened during an in-person visit. Next slide, please. And now I'm going to turn it over to Dr. Tanya Belcheff.
Thank you, Dr. Belzer. I'm Dr. Tanya Belcheff, joining you from Arizona. I'm pleased to be here with everyone today. The next few slides include some tools for the setup of telehealth services. Telehealth visits are structured much like a clinical simulation, where each session has a pre-brief, the clinical interaction, and then a debrief. Each remote visit should follow a similar outline. Before the visit, screen the patient for the appropriate visit type, instruct the patient on the telehealth platform, and obtain consent. When presenting the option for telehealth, make sure to let the patient know why other patients like telehealth. Inform them that patients are finding telehealth to be more convenient, that they can engage with a healthcare team from the comfort of home. There are no travel costs, no waiting rooms, no long queues, and less risk of spreading or contracting an infectious disease. During your visit, reinforce consent by asking for verbal permission to proceed with a remote visit before taking the history of present illness. And after the visit, collect patient satisfaction surveys to drive improvements in the telehealth services provided. Next slide, please. There are several examples of informed consent available through many of the resources listed in this presentation. A sound commercial telehealth system should have HIPAA compliance statement, examples of informed consent for that specific telehealth platform, and other support resources like billing support, a client portal, and secure messaging. Some practices will use a meeting software such as Zoom for ease and price. Utilizing these platforms is legal and acceptable, but the creation of the other components to augment the meeting software will be beneficial. Next slide, please. Clear directions and a dedicated person to provide support with logistics can help many patients who are not previously technologically astute to transition to remote care. This slide shows an example of an email that can be sent to patients to assist them with the setup of telehealth software. Communicating what to expect with your patients and your staff will ensure a smoother implementation process. Practices must identify the team members who will give the patients an overview of the software. Providers should screen and obtain informed consent and permission for the visit to be done remotely. Next slide, please. Here's a sample patient experience survey that can be modified for use immediately following a remote healthcare visit. Patient experience data is an essential element of any quality improvement process. Some vendors may have the capability to host a survey on their telehealth platform. If not, set up a practice-specific app or a SurveyMonkey to gather this information. Next slide, please. Most insurance companies will cover home blood pressure machines, and women can be encouraged to buy simple weight scales. Some practices are teaching their clients how to self-measure fundal heights. Fetal heart rate Dopplers, at least the accurate ones, are expensive, but some sites are still encouraging the use of these in addition to the reporting of fetal movement counts. However, most practices will rely on fetal kick counts as the marker of fetal well-being. The addition of a patient portal for sharing education materials, lab results, and between-visit communications will help optimize your telehealth visits. Next slide, please. Protecting privacy with face-to-face appointments is straightforward. Navigating privacy in remote visits requires a much more complex understanding of information security. Privacy considerations in telehealth applications are multifactorial. Privacy needs to be ensured at the originating site where the patient is located, the distant site where the provider is located, and through the modality, whether it be video calling, remote monitoring, or the patient portal. Patient privacy must be protected in all forms of digital communication incorporated into practice. When evaluating new technologies, check the fine print on the privacy policies and ensure encryption options are available. Does this platform collect and sell data for purposes other than patient care? Is the software easy to use and available on a wide range of operating systems? And remember, professionalism expectations are the same online as they are face-to-face encounters. Next slide, please. The pandemic accelerated the need for telehealth visits, and because of this, it might be necessary to obtain verbal consent before the remote visit. Signed informed consent may be added to the chart next time the patient is seen in the office. Signed consent is required in some states, but not in others. So when in doubt, have written consent. During shared medical visits, review the ground rules with the group to create a safe space. Participants need to agree that it's a safe space, that everyone's privacy will be protected. Keeping cameras on during group visits creates an atmosphere of accountability and engagement. If the software allows it, the host should disable the ability to record the sessions. And remind all participants that sharing screenshots or information from the group on social media violates the confidentiality rules. Links to meeting spaces should not be posted in public forums to ensure that only invited persons can attend the remote visit. Next slide, please. After appropriate screening by the provider, patients may choose to opt into telehealth services. That's a fine but important point. Transmit information such as lab results and other HIPAA-protected information to patients through the portal or another encrypted method. Always remember, Stark laws and HIPAA compliance apply in telehealth just as they would in face-to-face care. As telehealth becomes integral to patient care, midwives must be at the table as regulations become law at the state and national levels. From a public health perspective, it's vital to evaluate how patient data is collected, who's collecting the data, and how it will be used. Will the data collection equitably benefit all? The International Confederation of Midwives has identified the 3 pillars of midwifery practice to include education, regulation, and association. As telehealth increases in our practices, we must be cognizant and active change agents for policies that will impact telehealth practice. As the pandemic ends, the legalities around privacy leeway will have to be reevaluated and updated. Next slide, please. To ensure right care in remote visits, patient choice and accurate identification of the patient is critical. There are several other essential ethical issues to keep in mind. According to a review of e-health materials surrounding perinatal health done by Richardson et al. In 2018, the vast majority of e-health information centers white, cis, English-speaking, middle-class hetero bodies as the audience. They concluded that nurses, midwives, and the diverse populations they serve should play active roles in developing e-health resources. It's critical to be aware that at this time, there are limited frameworks for the assessment and development of mobile health apps. Telehealth visits may not be the best idea for pregnant persons who are in recovery for drugs or alcohol during pregnancy. It would be best to have open conversations with these patients about the risks of exposure to COVID versus the benefits and support that can be offered in face-to-face visits. Make sure to ask if a regular talk screen feels like an intervention that would help prevent relapse. Also be alert for body language that may signal that the patient is not feeling open or comfortable during a telehealth visit. Domestic violence has increased during the pandemic, and the partner may be sitting in the room stifling the conversation. Take the initiative to make the next appointment a face-to-face visit. Remember, patients may not disclose access issues. Do not assume that all patients have hardware, software, or space to have a successful telehealth visit. According to the Pew Research Center, access to fixed broadband can be as low as 45 to 50% of the population in rural and tribal locations in the US. And while broadband access is still low, about 81% of US adults have smartphones. Even though these numbers are higher, reliable connections and cell services are more limited in rural areas. Also remember, there's a lack of stratified outcome data for perinatal telehealth visits at this time. As you work on your benchmarking this year, make sure to add telehealth as part of your data collection. Next slide, please. In 2014, Holmner et al. Estimated that when telehealth visits replaced face-to-face visits, it's possible to decrease carbon emissions by 40 to 70 times. And in 2019, Vidal-Alabal published a study of visits provided over 18 months, offering over 9,000 remote visits. This study estimated that they reduced travel by nearly 120,000 miles, saved close to 4,000 hours on the road, and conserved about 3,000 gallons of fuel. Although there's a significant decrease in travel with telehealth visits, video conferencing and data storage in the cloud or on a server is not carbon neutral. Streaming data and storing data has net carbon emissions, and as the quality of the connection increases from audio only to ultra high definition, the carbon emissions increases. As the number of parties in a video conference increases, so does the net carbon effect. It would be safe to estimate that for every 2,000 hours of high definition video conferencing between 2 parties, planting 1 tree would offset that carbon footprint. Next slide, please. And finally, sociologist Dara Ivanova wrote a compelling article titled Post-Place Care Disrupting Place Ontologies. This article is a discourse on the upcoming advancements in simulated reality in healthcare. Ivanova compares and contrasts the concepts of post-place versus placeless and place-making in healthcare. We have an opportunity to create midwifery spaces within this new landscape of telehealth. What does that mean? How do we engage in these post-place spaces in a meaningful way? Midwifery has been meaningfully changing exam rooms as a means to elevate care for years. While moving through telehealth visits, keep this concept in mind. How do we convey the core values of midwifery through the space of telehealth? How will we use telehealth spaces to create genuine virtual closeness, inclusion, and a sense of belonging? I would like to introduce Heidi Loomis, who will be presenting next.
Hi, everyone. Thank you, Dr. Belcheff. Greetings from Central Pennsylvania. For the next several slides, we are going to review some of the details that can help to support functional, successful, and satisfying televisits for both patients and clinicians alike. Next slide, please. Thank you. First, we want to make sure that our cameras and microphones are in good working order. These can be tested ahead of time. Dr. Belcheff alluded to that a little bit already. We want to make sure that we're ready for a close-up connection. Think of the setup of a visit as using lights, camera, action as an approach. For example, are my lights bright enough that the patient can see my face well? Am I wearing clothing that won't be distracting to my viewer? Second, we want to verify that our internet and wireless or Ethernet quality are adequate and that we have a backup should they go down. Dr. Belcheff talked about that already a little bit as well. That said, there are times when some of these things are out of our control. Some clinicians will use a second monitor in addition to the main computer so that patients can be viewed on one screen while having access to notes and orders on a second screen. Third, by this point, we've already ensured that our connection is encrypted for patient confidentiality. Next slide, please. Thank you. When we consider each patient's individual needs, we want to think about whether they might be using a telehealth platform for the first time and any logistical or emotional challenges that that could present for them, whether their first language is congruent with our own, and if not, interpretation might be required and need to be accounted for ahead of time. They may have vision or hearing or cognitive impairments that we would want to consider that would require special assistance in order for them to navigate the technology. And if the patient has a hearing impairment, perhaps they might want to use headphones to hear our voices amplified, and some platforms will also offer closed captioning. And for those patients with cognitive impairments, a family caregiver may be able to help them orient to communicating with their clinician on the video. And we want to think about whether there might be other members of our interprofessional teams who should also be present for the visit with our patient. These can be decided on in advance and can include whom and when and how to make those transitions as well for our patients. Next slide, please. So during the visit, we want to try to remember to look at the camera, to make eye contact with our patients as often as we can, and not just look at the video display of the patient on our screens. Some providers will put googly eyes or a sticky note right next to the camera to remind them to look at the camera, because this is not necessarily intuitive for most of us. As best we can, we want to strive to establish a webside manner and to take our bedside manners and translate them to interacting with a patient over a screen. Some of the things that we do in person to establish rapport and develop trust with our patients and to help them feel relaxed, we can also put to good use during our virtual visits. We can pay attention to how we speak. It can be helpful to slightly lower the pitch of our voices and to speak slowly and clearly, and to make sure that the patients can see our lips for their maximum visual input. And for older adults, it's recommended that we utilize the age-friendly system of the 4 M's. What matters to them? Have their medications been reviewed and evaluated? How is their mentation? And how might their mobility affect their well-being? Finally, we want to ensure that our interaction comes to a strong conclusion by verifying that we have addressed our patient's priorities. And as we come to the end of the visit, we want to make sure that we've spent enough time on what matters most to our patients. And in planning for follow-up, are there instructions for the patients that we want to share or include? Are there other members of our team that we need to connect with on behalf of the patient? Does a family caregiver need additional support? And that may require a separate telehealth phone call or a video visit for the caregiver, possibly, for example, with a team social worker. Whenever possible, it's helpful to let the patient end the visit first. Just as an in-person visit, we want to allow the patient and the family caregiver to ask any final questions they may have. And then you can say, if you choose, I'll go ahead and let you end the call when you're ready. And this allows the patient the chance to voice any concerns that weren't already addressed during the visit. Next slide, please. And of course, there are benefits to telehealth relative to in-person visits. These have already been addressed, some of these in this presentation so far. But to summarize, telehealth does protect us and others from COVID. It allows for less time in the car. It improves accessibility to our care and can be more convenient for clinicians as well as for patients. It can actually be even more friendly in some cases in that we are communicating with patients while they're in their own homes. And we can recognize that telehealth can personalize our care in creative ways. And most patients, once they have cleared some of the initial hurdles, actually prefer telehealth. So sometimes even the very best laid plans can go awry for all of us, even in ways that can be funny. So there's some quotes about this online, but one that I found was that there was an oncologist in New Jersey who quoted that she had just spent an entire telehealth visit looking by accident on the part of the patient at her ear canal. So, okay. Next up is Martha Harvey, my colleague.
Thank you, Heidi. My name is Martha Harvey. I am in upstate New York. So I am going to approach this in a little bit different manner, which was more about the reality of everything that sort of happened and where we've been and where we're going. When COVID-19 hit last March, we suddenly had to rethink how we were going to provide prenatal care, and we had to become very creative. We as midwives have always known that we really don't need to see patients for as many prenatal visits. So in pulling up the ACOG recommendations that were also endorsed by fetal maternal medicine, these were received as guidelines that we could use to set up to decrease our patient potential exposure to COVID, and therefore providing telehealth visits. So in late March, we started to do some of these visits via telehealth. And many of us, we had very little guidance and had to adapt very quickly. We had a few fumbles, but as time went by, we were able to adapt the recommendations and to accommodate our patients in our practice settings. So general guidelines, and I don't want to go over a lot of the same details that we've heard before, but the number one priority with COVID-19 was to prevent the spread of the disease. And so the number one thing was to decrease the amount of exposure. Social distancing to be at least 6 feet, if not feasible, extended dividers and other precautions. I mean, I was there the day in our office where we decided that the waiting room, we pretty much cleared out all the chairs. We took away all the magazines. We had patients call us from when they arrived so that we could bring them straight up and go straight into an exam room. We were also told at that time no elective or urgent visits, to postpone those. And each patient should be called to decide if they really needed an in-person visit at that time. Any visit that could be done by telehealth, we were told that we should probably be doing them that way. And also with the limited support person being able to come in for visits or access to any of the healthcare facilities, that made a big difference to our patients that we were seeing. As mentioned previously, the use of telehealth visits has impacted on our education to our patients, but also by, having patients pick up blood pressure cuffs and talking to them about importance of fetal movement and kick counts. It also is a way to really teach the pregnant patients to increase in their self-awareness, therefore increasing their own fetal surveillance. And this enhances responsibility and self-care that can be continued for a lifetime. So what great life skills we're trying to teach our patients. Next slide, please. One of the quick visits that we really pushed into telehealth visits were postpartum visits. And many patients in the past had always told us, we see you so often. You see us so often during your pregnancy, but, and it kind of crescendos up to the end. We're in every week and then boom, we have a baby and then don't get seen for 6 weeks. But telehealth visits have really helped us connect better with our postpartum patients. And, as for timing, it depends on which setting women are delivering in, but newborn assessment, making sure she's doing okay, make sure the baby's doing okay, like day 2, but also, blood pressure checks. Women that were having problems with hypertension during pregnancy, having them check their own blood pressures at home and calling them in versus bringing them in, especially with a newborn in tow. Lactation visits, it was opened up a huge opportunity to really help women with lactation concerns. Of course, postpartum depression scale and, and screening and ways of getting referrals out more efficiently and really treating and really listening to women. We know that this is the anxiety level of our population right now is very high, and postpartum women are definitely included in that. It also was a time for us to follow up with shared medical visits, and maybe like your gestational diabetics that all of a sudden we weren't treating the diabetes anymore, but to make sure that they had follow-up and were being followed up by their primary care providers with diabetes screening. So this opportunity also, it helped, like I said, with the breastfeeding services to make sure they had enough supplies. It also provided us time in that week 4 to 6 that gave us a platform to discuss in better detail contraceptive counseling, preconceptual counseling. When we go back to contraceptive counseling, we could order, if they wanted to start on birth control pills, we could just order them. It didn't require an inpatient visit. But it also saved us a lot of prep time if women wanted the LARC methods, and that we could go over risk and benefits ahead of time so that they could just have the appointment to come in and either get their IUD or an implant. It also was a really good way to interface with the domestic violence screen. And we know during COVID, the domestic violence rates have gone up. And again, we see them in their own homes, or you're talking to them in their own homes, so they may be more forthcoming with information. Other counseling that it would be really, gave us a great platform to screen for was smoking cessation and drug abuse counseling, alcohol counseling. So it gave us another way to contact and to connect. But we often thought, okay, this is just prenatal care. But now we know that this is a huge platform for us to do so much more. That we just don't need to limit our visit, the telehealth visit knowledge, that we can provide prenatal and postpartum care, but we also can do a lot of GYN visits with telehealth, especially at the beginning when we were pushing off any non-urgent visits. We pushed them out for a while, so our GYN log has backed up a little bit, but many of those women we can see telehealth-wise. From contraceptive counseling, discussion of method, prescribing, and doing all sorts of phone triage and things about IUDs and implants and Also with college students going back and getting their pills and reminding them there's also a thing called the pill club where they can get their pills sent to them. But we also can use this for general health issues. And we as providers are not just limited to this list above here. Of course, the anxiety, depression scale, follow up with lab work, infectious disease, talking to women about their HIV risk and sexually transmitted infection prevention counseling. It's another platform to be able to talk to women about fertility tracking and another way to provide medications if medication-induced terminations are desired. Again, with the blood pressure screening and having women know what normal is for them and how that all puts into place. But during our regular GYN visits, we most of the time are talking to them about healthy diet, activity counseling, obesity screening, but also with our mature women, talking about fall prevention counseling and urinary incontinence screening, but also, even stretching it a bit further that counseling them about what are their breast cancer risks. Are they at risk? Should they be BRCA tested? And skin cancer risk. So many preventative services for women's health can be involved, especially if it involves screening, assessment, and counseling. So if we have all those components, these all can be put into a telehealth visit versus an in-person visit. Or it may just push out that in-person visit out a little ways where it may be safer for them to go. Next, I just want to talk a little bit, and I know Cassie already did talk a lot about billing and for digital and telehealth services. But I just wanted to mention a couple things, and just to reiterate that there were major changes put into place by Medicare during the pandemic so that it would cover more. And most commercial payers usually will follow along with whatever new Medicare guidelines are. So next slide, please. So the thing is, it's just like I'll reiterate what Cassie said is you need to know your state. You need to know your state rules and regs. You need to know where your patient is and where are you at the time that you're providing telehealth. There's a list of all the telehealth codes for services, and telehealth can be audiovisual, and it also can be phone. So usually it is based, the ICD-10 codes are procedural codes, and these are used by the facilities, and it gives them the diagnostic code. While, the next slide, please. The CPT codes are ones that are, we usually look at as based on more time frame and how much time the provider was providing the service. And like I said, these are all on websites, and they're probably already in your EMR system or electronic record system. Telephone calls that involve only clinical staff cannot be billed, though, using those codes. Only if a provider is using those. All right, identifying how do we identify measures of success? And again, we haven't done telehealth very long, so therefore there's not a lot of research about telehealth. But what we are finding is that it gives you this whole snapshot, like I said, into people's living situations and their surroundings. So it gives you a much broader look at how this person is doing in their own environment. You may want to implement when you're implementing this into your practice, think of how telehealth may improve your outcomes by patient experience and patient satisfaction, while also reducing cost. So when we're looking at this, it reduced costs by their wait time, them waiting around at travel time, and also a couple things that we don't think about too much with our cost is that there's a lot less cancellations, no-shows. It doesn't require a nurse visit to set them up. and we can do most of the billing all through electronic records. So, so it does have some improvements that we can make, but it also seems to give a good continuity of care. It's efficient care. It gives good communication. And also patients realize that we're easily accessible and that we can be reached and contacted. For providers, it seems to be a little bit less burnout, a little less turnover rate, and appointment lengths of time is probably a little less. Although, next slide, please. Although there are some barriers, which anytime there's a positive, there's always a potential negative. And, you know, the number one priority, though, is that during COVID, is that we need to prevent the spread of infection. But also adapting to technology, including, you know, if inconsistent reimbursement models happen, if we talked about the interstate licensing challenge, the legal and regulations, and concerns over privacy, and making sure that there is a safe logistical place for them to be providing telehealth visits at home, but also us at work, that we're not in a room providing telehealth visits, that we're interrupted with people constantly behind us. So that is it for me, and I would like to now hand this over to Dr. Judith Butler.
Hello, virtual audience. I'm Dr. Judith Butler here in Tucson, Arizona, and I'm here to talk about shared visits, and specifically in this case, we'll be discussing the centering pregnancy model of perinatal care. Next slide. The centering pregnancy model uses these 4 strategies: client engagement and empowerment, self-management, and social support to not only engage the participant, but to drive improved health outcomes. So let's take a look at each one and some strategies that we've used to implement them and how we can implement them in telehealth. Next slide. We know that as we engage clients in their own care, we improve health outcomes. This just makes sense because as we open the communication pathways, we learn what motivates and drives our clients. And by learning what they value, what their preferences are, and using that knowledge to find common ground, we build trust and ultimately have the opportunity to have us all on the same page. And this improves individual as well as population health, which is the goal for all. Next slide. Keeping a group of 8 to 12 pregnant clients and their possible partners engaged can be a challenge when they are physically in the same space as the provider. Having us all on webcam can put up some barriers, but there are several ways to keep them actively engaged and improve their learning while also building that sense of community within the group, even while in the virtual setting. A few of my favorites here are the whiteboards, the breakout rooms, and the polls. The whiteboards I've recently learned, we can all be using that whiteboard at the same time, all of the participants as well as myself. We can write on it, we can draw connections, and that really involves the whole group and keeps us all mobilized together. The breakout rooms are something that we use especially for one-on-one time that we do in centering pregnancy at the beginning of each session. And what we have found is that if the provider stays in the room, and the participants can come and go. And I think just as Martha was saying, or maybe it was Heidi, that they end the visit. They actually leave the visit and go, and then the next person comes in while I stay and wait there. And the last thing is the polls. That is something to involve people as you start to see them sort of drifting off when you have 8 or 10 people in a group. Next slide. So client empowerment, another aspect of centering pregnancy that is so vital to improved health outcomes. The definition above, the acquisition of motivations and abilities that clients might use to improve their participation in decision-making and thereby improve their power in the relationship with professionals. This is so key. However, for me, it's the second bullet point that really makes it important. The client needs to be willing and able to interact with the new system. And that is why the previous presentations included giving everyone clear and simple instructions, and that is so crucial. So giving them some of the knowledge of what they should expect, the benefits that they're going to receive, as well as actually how to can decrease the stress and lead to them really enjoying these group centering visits via telehealth. Next slide. So how do we empower them? As adults, whether defined by age or the life situation of pregnancy, we all come to these sessions with life experiences and knowledge. Facilitation is the conscious act of drawing on that knowledge, no matter how large or small, relevant, or that may be a stretch, to build upon each client or couple and empower them. The method of ARR, by asking a question, either a client can ask that question or we, the facilitators, can ask a question, asking if anyone knows the answer to that, what they've heard, what they've read, eliciting their responses and their knowledge, gives us an opportunity to dispel some myths. We can share evidence-based sites and knowledge, and then we can touch back with the asker to make sure their questions were answered and to thank them for sharing a great method. This is a wonderful way to build individual and group empowerment. And while we are not live and may not have a blood pressure to look at or a weight, it gives us the opportunity really to refocus and to use what we do have. We can talk about risk factors, prevention, and a mutual dependence on the client with the provider to obtain their best health outcomes, and they're really altering the power structure, which is again empowering the patients. Next slide. The internet has provided the health provider team as well as the client with a plethora of evidence-based and sometimes not so evidence-based applications. We also find that clients of reproductive age are super users of the internet and are prime candidates to participate in the management of their own care and often even teach us ways to use it that we didn't know. Health apps such as WebMDs, symptom trackers, contraction timers, kick counters are just the tip of the iceberg, and again have the potential to empower the client and engage them in their care, and then potentially diminish poor health outcomes by increasing awareness in preventable actions. And that's what we're all about. Next slide. And in the time of COVID, which doesn't seem to be going away soon, we have the opportunity to improve access to care. One segment of the population that anecdotally participates less in centering pregnancy, but whom we love to have join us for their experience and knowledge, are the women who've already had babies. They often can't join due to other childcare issues, but telehealth has shown to be a wonderful mitigator for this barrier. Next slide. Here are a list of practical tips, and I encourage you to go to the Centering Healthcare Institute webpage to learn more. One of the easiest tips here is the gallery view, and this can enhance the sense of community when we're not physically in the same room. It's amazing how you can go through a whole session and realize that they are not connecting with each other because they can't see each other. They didn't know that one simple little trick. Next slide. And as with every medium, there are pitfalls. I hope you can learn from some of our flubs and struggles, and that centering pregnancy via telehealth can be a boost to your site and clients as it has ours. And now I'd like to turn this over to Dr. Audrey Perry. Thank you.
Thank you, Dr. Butler. I'm Audrey Perry. I'm the Clinical Director for Midwifery and Women's Health at Frontier Nursing University. And I want to thank you for joining us during what is a phenomenal week of the nurse and midwife, and really a celebration of you. So as we have discussed best practices in telehealth, we've talked about billing related to telehealth. We've talked about the provider role and responsibilities related to telehealth, the structural supports that are needed for telehealth, and legal issues related to telehealth. So what I aim to do is just briefly discuss telehealth practices in the context of the culture within which I practice. So we have already discussed how essential it is for providers to examine the cultures and communities that we serve in order to provide the best telehealth services that we possibly can. We must acknowledge that, of course, every individual that we work with will have their own lens in which they work through to determine if telehealth works for them. So a little bit of a window into the world within which I work. I largely serve an Anabaptist community. So if you're not familiar, which many of us are not, Anabaptist communities are defined as religious communities that deny the validity of infant baptism. They are baptized believers only when they choose to, generally later on in life. They advocate for social and economic reforms, as well as a complete separation of church and state. So for many of you, once the community that I serve is both an Amish and a Mennonite community. So those terms are probably more familiar to you, but the broad term for those communities is Anabaptist. I am not an expert. I've lived within the community, externally of the community for many years, but I continue to just learn and hope that I serve the communities well. So if you would like more information, there is a link in the slide if it's something that interests you. Elizabethtown College, which is near me, has a great national, actually international center with lots of information related to the Anabaptist community. So in brief, when I talk about the context of telehealth in these communities, I have to acknowledge that within these communities, they really selectively use technology, and some might say that they have a very media scarce culture. They very much value face-to-face interaction, so you can see how telehealth is a bit of a challenge to their cultural norms. They also have a very strong belief in a right to self-determination, strength in the community as central, and then that God is the ultimate healer. Their pace of life is a lot slower than ours. Also, if you're thinking about the Amish community, it can take a horse an hour to go 10 miles. So that impacts their lifestyle and the pace at which they live. So as a provider serving these communities, I always have to acknowledge these differences, but they have been unique during COVID. And it's very much because my lens on COVID is quite different than theirs. And that's true of all of you, that your lens is different than those that you serve. But in a community that is so scarce in terms of their media consumption, it has definitely presented some challenges and some conversations around the value of telehealth for them. And some might say that there's really a chasm that's been created between the community that I serve and their reaction to COVID and the larger community in which I live. Okay, so we in our practice have come to term what we offer our clients as slow telehealth, and truly it's really because of how we're navigating the option of telehealth, and we're using a model of shared decision making with our clients. We've intentionally shared COVID information with them very intentionally because we know that we are a source of information for them. We have tried to share evidence-based information with our clients. Each client, of course, processes this information individually. They do see the midwife office as a place of support, as a place of community connection, and also of health prevention. They are thinking about many of the same challenges that, of course, the communities that you serve are in choosing telehealth. As was mentioned before, sometimes it's a great fit because they're juggling what am I going to do with my children who are all at home, and it can be a huge benefit for them. But again, it's all within the context of how they are viewing the risk of COVID versus the sense of community and support that they really feel when they come into the office. So as I mentioned before, we have coined what we're doing with our clients slow telehealth because very little happens truly in our community very quickly. Some of the unique approaches that we have found work with our community is, of course, that it is a shared decision whether they choose to participate in telehealth or not. Within the Amish and Mennonite community, the power dynamic is a little bit different than in the larger, I think, culture in some ways. It is very difficult for our Amish and Mennonite clients to oppose any of our recommendations. So it can be, it's very important that we give an open door whether they want to participate in telehealth or not. We often do split visits. So part of those visits will be via phone. And then perhaps those visits that involve hands-on assessment, we are doing at the office, and that serves the needs of our clients. We're sending them lots of information and pictures as much as possible. If they have a smartphone, we will use that. They do often. And then, of course, we're using text often. So again, for some of our clients, it's working very well and they feel very comfortable with those telehealth visits. And then we have found that for many of them, they feel a little bit more comfortable still coming in to see us for a portion of that visit. We've also had our visits, as many of you probably had, occurring outdoors. So I think that we can carry the principles of midwifery related to innovation into our practices, as Martha has already alluded to, when we're serving our communities. So in closing, the hallmarks of midwifery can be firmly centered in telehealth. We hope that we have provided you some tools to incorporate telehealth into your practices to help you to navigate what is new for many of us. We hope that you can walk away with this with a better understanding of approaching this in a financially prudent manner. We hope that you have greater insights into best practices. I think we've shared a lot of information just related to regulations, what do these visits look like, making sure that we have clients consented, that they feel comfortable. So I really hope that this will help aid you in your practice. So I hope that you can incorporate the hallmarks of midwifery, such as evidence-based care, inclusivity, person-centered care, partnership, advocacy, community-based care, and honoring normal physiologic birth as a foundation for what I like to call your telemidwifery practice. You can see on this slide that we have multiple links, which we hope will serve you well as you continue on your adventure through telehealth. These links are constantly being updated and changing, and we have found them as we've put this presentation together to be very helpful. So once again, thank you for joining us during Nurse Midwifery Week, and we hope that you find some time to celebrate all that you've accomplished and all that you offer to the families that you serve. And we want to thank you as a university for all of the work that you do with us and beside us.